Hey everybody, Dwayne France here. I'm the founder and host of Headspace and Timing, a blog, podcast, and series of books that are designed to change the way that we think and talk about veteran mental health. I'm coming with an unscheduled live today. I wanted to go ahead and provide some video support for a series of webinars that I'm doing. We've done our second webinar already, but this I want to take the time today and answer some questions that were left over from the first webinar. But before that, I would like to give some people some information about the webinar series as a whole. If you haven't seen it, you can go to veteranmentalhealth.com/NAADAC. That's NAADAC. I'm going to have a number of these links in the comments below the video whenever it's completed. But basically, as you can see, you can actually access the webinars here if you go to veteranmentalhealth.com/NAADAC. You can click on some of the webinars that have already been completed, and you can view the on-demand video after you register, or you can go back and you can actually click on those videos that you haven't, or the webinars that you haven't accessed, and click on those to register. Again, the easiest way to get there is to go to veteranmentalhealth.com/NAADAC, NAADAC. So after we completed the first webinar, there were a series of questions. There's a question and answer period during the webinar, but there were also a number of questions that were asked at the end of the webinar. We do have them at veteranmentalhealth.com/NAADAC1. There's actually going to be a dedicated page to each of the webinars focused on a number of different things, the references that were used included in the video or in the webinar, as well as a PDF copy of the answers to these questions in this video. So I wanted to take some time and talk about what some of the questions were. So the first question that we had received, we were talking about comprehensive veteran mental health, and one of the individuals asked about EMDR, eye movement desensitization and reprocessing, and whether it is used for veterans. Another user asked, isn't it dangerous to be pushing EMDR when prolonged exposure is clearly the frontline treatment for PTSD? And my answer is, I personally believe that it would benefit the client to have the treatment that works best for them. Here's a direct quote from the recently released VA DoD clinical practice guidelines for the management of PTSD and acute stress disorder. For patients with PTSD, we recommend individual manualized trauma-focused psychotherapies that have a primary component of exposure and/or cognitive restructuring to include prolonged exposure, cognitive processing therapy, eye movement desensitization and reprocessing, specific cognitive behavioral therapies for PTSD, brief eclectic psychotherapy, narrative exposure therapy, and written narrative exposure. As you can see, EMDR is listed as a recommended intervention along with prolonged exposure and a number of others. I believe it's important to prepare clients for these types of interventions and maintain association with colleagues who are certified in other interventions in order to best meet the needs and the responsiveness of the service member, veteran, or military family member to the treatment. The next question was, in this webinar, I'm using the term addiction. In the asker's opinion, differentiation should be emphasized between addiction and substance use disorder. They asked if I was implying that they are the same. That is a great question, and there certainly is a distinction between addiction and substance use disorders. There's no implication on my part that they are the same. Substance use disorders are clinical diagnoses according to the Diagnostic and Statistics Manual, while addiction is applied to an individual's compulsive use of a particular substance, thing, or activity. As mentioned in the webinar, there are process addictions that military-affiliated population experience that go beyond substance use and therefore substance use disorders. The broader category is inclusive of NAADAC's commitment to all addiction professionals, not just substance use disorder treatment providers. Another question I was asked is ECT, electroconvulsive therapy. Is ECT ever utilized? Electroconvulsive therapy is a medical procedure that's often used for extreme cases of medication-resistant depression. While effective, the side effects are significant and it's an invasive procedure. An emerging alternative is transcranial magnetic stimulation, which is less intrusive and have shown benefits. It's currently FDA approved to treat medication-resistant depression, but current studies are underway to determine the benefit of alleviating symptoms of PTSD and other trauma-related disorders. Understanding that I am in Colorado right now, and so anytime I do a webinar, especially around substance use and mental health, I kind of expect this particular question. I'm often asked, what is my take on medicinal marijuana? Now, I recognize that many veterans indicate that it provides relief from chronic pain, reduces anxiety symptoms, and provides relief from hypervigilance, reduces anxiety. I believe that there are some benefits from the cannabinoids or cannabinoids, but there has not yet been the ability to fully remove THC from the CBDs. I recognize that there's a number of type that really take a lot of the THC and they're just very, 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 very trace amounts, but there are some trace amounts and some dosing concerns. Generally, I am not in favor of using anything external to us to do what we can do for ourselves, like regulate emotion, reduce symptoms, and control our behavior. This is not solely limited to medical marijuana. I feel that it's more beneficial for a client to manage their own symptoms without medication of any kind or relying on an external source for comfort or relief. It's not to say that medication is not beneficial and that a combination of therapy and medication may be what's best for the client. But relying on an external source to do for us what we can do for ourselves means that we're not learning the coping techniques that helps us regulate when that external source is not available to us. I do believe that there needs to be more research into the benefits of CBD for symptom relief, which is limited by the current federal regulations. If we can provide and prove that the beneficial effects of medical marijuana without the harmful effects, then that would be best, in my opinion. Another question which I alluded to earlier was, does the military use EMDR? And if so, do I think EMDR is best used early on so that one's addictive behavior can be avoided to some degree since they're not needing to self-medicate as much since the replay of the PTSD isn't going on as loudly in the prefrontal lobe. Again, as I mentioned before, the Joint VA-DoD clinical practice guidelines do list EMDR as a primary intervention for PTSD. And using those interventions that alleviate symptoms of PTSD can certainly lead to reduced reliance on substances to manage those symptoms. As identified in the webinar, the true underlying cause of the client system has to be identified because EMDR and exposure therapy are beneficial for processing traumatic events, but other interventions are indicated for anxiety that's not related to trauma, same thing for depression, a lack of purpose in meaning, etc. Substance use may be tied to symptom relief in these other conditions rather than just PTSD. Another question was, nowadays more and more military members may experience combat without experiencing traditional combat. Should we consider anything unique when providing counseling services or recovery support for a veteran who was involved in drone strikes and presents with PTSD symptoms? I think the primary thing here is to begin working with clients without any preconceived notions about the nature of their trauma. Regardless of where or how the client experienced that trauma, clinicians must understand that it's the client's subjective response that is important to consider. I do have an article in the PDF that was written in 2014 that identifies that there's not enough research on the psychological impact of remote combat, but indications are that it does impact some service members and veterans adversely. Part of when I was talking about this, and we were talking about learned helplessness and emotional dysregulation, and I had mentioned Dr. Martin Seligman and his work specifically around learned helplessness. The question that was asked was, I mentioned Martin Seligman earlier. What was that? Was that the positive psychology guy? Yes, it was. Can I say more about his affiliation and work with the military and veteran culture? I did mention Dr. Seligman, and I did not mean to imply that he expressly applied his concepts to military and veteran culture any more than, for example, Viktor Frankl or Irvin Yalom have. Dr. Seligman and his team at the Positive Psychology Center at UPenn have provided resilience training for the United States Army, but I was simply referring to how to apply his concept of learned helplessness to the military experience. One guest asked, had I written any books on today's topic where they could learn more about military and veteran culture? Longtime watchers and listeners know that I have had a couple of books out. Actually, you can see a couple right here, a little bit of product placement. But I've not yet written any books covering the comprehensive veteran mental health model. I have been in discussion with editors in the past, but it is a work in progress. I've written about this topic extensively on my blog. Relevant links can be found on the webinar notes page. Another individual asked, can a family member of a veteran experience PTSD from hearing about their loved one's story? Maybe the loved one was overseas and described an event in great detail over the phone and it traumatized the spouse. How can we help them? As we know as clinicians, vicarious trauma is possible when hearing repeated descriptions of trauma. Additionally, criterion A from the Diagnostic and Statistics Manual for PTSD is the person was exposed to death, threatened death, actual or serious injury, or actual and threatened sexual violence in the following ways: direct exposure, witnessing the trauma, indirect exposure to aversive details of the trauma, usually in the course of professional duties. That's the vicarious trauma, such as mental health professionals, first responders, and medics. But one more criteria that could fit this question, which is learning that a relative or close friend was exposed to a trauma. So it is likely that hearing a traumatic event in detail by a loved one could possibly result in traumatic stress reaction, which, left unresolved, can develop into PTSD. More likely, however, is the ambiguity that's associated with sharing traumatic events. In my personal experience, a veteran will not likely share the details of the traumatic event or events with those that are closest to him. And helping a family member with vicarious trauma is the same as helping the veterans themselves with primary trauma, using evidence-based treatments to resolve the traumatic stress reaction. Additional support may be needed to help understand the changes that have occurred in each family member individually and in the family unit as a whole. And the final question that was asked is, what are the most prevalent and dangerous substances used by vets or military members who also have PTSD? When asked this question, the first substances that came to my mind for me personally were alcohol, opiates in various forms, and methamphetamines. An article on the prevalence of substance use disorders in the military population identified that the most commonly abused substances are alcohol, prescription drugs to include opiates, and marijuana. Nicotine dependence is also identified as a significant issue. Now, I'm describing the intent of the use to the point of dependence based on alleviation of symptoms rather than of the use itself. Alcohol use, smoking, prescription medication use, and marijuana use in some locations is not illegal or illicit. It doesn't mean that it's wrong. Instead, the reason behind why the service member or veteran is using the substance and the frequency and quantity of use is the issue that must be addressed. So once again, I want to thank you for taking the time to watch this short video. I want to be able to provide answers to these questions in as many ways as possible. Again, if you are interested in learning more about the webinar, you can go to veteranmentalhealth.com/NAADAC, and you can access the webinars that have already been presented and the webinars that are coming up. I will be presenting a video for frequently asked questions in this format and a number of different formats in order to make it most accessible for individuals to be able to access. Thank you once again for taking the time to learn more about service member, veteran, and military family mental health. Thank you.